And thank you for the invitation. So we are here to talk about the clinical genome resource, ClinGen, and our partnership with the variant database, ClinVar. So we have many slides put together to go over. We have a lot to cover, but feel free to keep this informal. And if there's anything we're talking about that you'd like to hear more information about, please feel free to bring that up. We want to make sure this hour is the most useful to you as it can be.
I think, did you say everyone is muted? I was trying to think, if people have questions, should we be checking the chat as we go along, or will people ask questions, I guess?
Yes, everyone is muted upon entry. Again, you can unmute yourself by dialing *6 or just clicking on the icon. And again, you can use the chat box. So I'll be looking out on the chat box for you.
And also, so feel free, if questions come up, anyone, you're welcome to, as Danielle was saying, we want this to be as informative as possible for all of you. So if there's something we're talking about where you'd like more information, feel free to ask then and we can discuss it more.
All right, and can everyone see the first slide?
Yes.
Okay, great, then we'll just go right ahead and get started. So we were invited, I think it started just talking about ClinVar submission, but we thought we would just give you a bit of background about ClinGen because that is the project that Stephen and I have both worked on now for many years and the reason that we work so closely with ClinVar. And then we'll talk about using ClinVar just as a resource to learn more about variant interpretations. And then we'll move on to submitting your own data if there is data you maintain as a lab director or a clinician and wish to share in a public forum. So first, a bit of background about ClinGen. Our mission statement is to create a central resource that defines the clinical relevance of genes and variants for use in precision medicine and research. And we currently have over 20 working groups working towards this lofty goal. We've been funded since September of 2013, so we're actually in our 6th year. And we are a consortium of 3 different core U41 grants funded by NHGRI. So Stephen and I work with Dr. Heidi Ream at the Harvard Brigham and Women's funded site. And this picture on the left represents ClinGen's critical questions of all the work we do. This is how we boil it down. The first focus is on sharing genetic and health data, so bringing together all the stakeholders in the clinical genetics community, patients, clinicians, laboratories, and researchers, and facilitating ways to standardize and share data amongst them. And the next, something you may have heard ClinGen talk a lot about if you've heard our talks at meetings, is curation. We talk about gene curation, variant curation, actionability curation, and over the years we've developed standardized frameworks for assessing evidence to evaluate variant pathogenicity, gene disease associations, and the clinical actionability of genes and diseases. We do have over 40 expert panels in different clinical areas who are addressing specific sets of genes and variants using these frameworks. And finally, our third overarching goal is dissemination, how to get this information out to the community that needs it. The main way variant data is shared is ClinVar, which we'll be focusing on today, and the other is ClinGen's website, clinicalgenome.org. And we hope the end goal that all this standardization, sharing, and curation work does help us improve the knowledge we have about genomic variation and in turn improve patient care. And over the last 6 years, we have built a collaboration of close to 1,000 working group and expert panel members from around the world. Almost 30 countries now are represented on our working groups. So though there are 3 grants and the main centers that are funded is a small number, just the collaboration that's going on across the world towards these goals has really grown and continues to grow. So we just wanted to highlight the sharing aspect. Why are we so focused on sharing clinical information? And when this grant started in 2013, there really was a lack of venue and also drive to publicly share interpreted variant information, particularly from the clinical setting. There were standards in place to share research data, but no real mandate to share clinical data. And there's still no mandate, but we do have several professional societies who have put out statements over the last few years, including the American Medical Association, the National Society of Genetic Counselors, and ACMG, endorsing the safe and secure for the patients, but utility of clinical data sharing. And so that's something ClinGen's really taken to heart to educate the community on how they can do so. And our main question that we get about ClinGen, and I'm sure our friends at ClinVar would say the same thing, is the biggest question that we get is what is the difference between ClinGen and ClinVar? So we hope to clear that up for you today, but again, I'll talk about ClinGen, which is the project, the consortium of people on that map we just showed you who are really working towards sharing data, coming up with standards and best practices for sharing data, and encouraging everyone to share their data with this archival database, ClinVar. ClinVar is one of the NCBI databases, so brought to you by the same folks who brought you dbGaP and dbVar. It is separately funded from ClinVar. It's funded by NCBI. So we work closely together towards the goal of sharing, but we are two different entities. And not only is ClinGen just cheerleaders for data sharing, but we are also generating a fair amount of curated data to submit to ClinVar. So just want you to keep that in mind as we go through the rest of the presentation about ClinVar itself, that we do have what we call variant curation expert panels. The different clinical domains that they are in are listed below, and when they go through this process of becoming an approved expert panel who has a defined gene disease scope and has specified the ACMG AMP guidelines for sequencing, for interpreting sequence variants for their scope, they can then interpret genes by those criteria and submit them to ClinVar as an expert panel. And I know we're on here with the newborn screening lab, so there are several inborn errors of metabolism groups through Mike Watson's participation at the ACMG grant site of ClinGen. So there is more and more expert curated data in the inborn errors of metabolism that's going in there. So hopefully that will be of use to you in your work. And then finally, the dissemination component we'll focus on today is ClinVar itself. So with that, before I get on to ClinVar, if there's any questions about ClinGen, please let us know. All right, then I will proceed into more detailed about ClinVar. So like I said, it's a public archive of variant and phenotype assertions. And these can come from any entity who's really using and interpreting this data. The main driver right now is clinical laboratories, but also researchers, expert panels such as the ones I just introduced you to from ClinGen, and other databases can submit data. And what sets ClinVar apart from the databases like dbSNP and dbVar is that not only do we aggregate genomic variants in this database, but tag it to an interpretation as well, a clinical interpretation. So ClinVar, the database at NCBI, facilitates the evaluation of variant and phenotype assertions by archiving those submitted from the community and by aggregating the interpretations that are received from submitters, and to determine if there is consensus about an interpretation for a given variant. However, ClinVar does not interpret variants, so certainly the quality of information people find in ClinVar, they believe may vary, but it's never because ClinVar classified something as the wrong thing. ClinVar is the liaison who's doing all the work to aggregate everyone's data, but all the assertions in ClinVar came from those submitters.
And that's an important point because we occasionally, like in talks, people will say, well, ClinVar says pathogenic, and it's a way we kind of say, like, somebody who shared their data in ClinVar says pathogenic. It's not ClinVar themselves that are doing any of this interpreting. Again, they are just an archival database, so it's important to sort of point that out.
And one thing from my time as a genetic counselor in clinic, when we talk about, putting, there may be interpretations that are discrepant we'll get into, or that maybe aren't of the highest quality. We don't want to get there out in the public. And the thing is, well, it is likely already in the public through test reports, but by aggregating it publicly, you're really bringing it to light. And I think that's one of the biggest benefits of data sharing that we've found so far, and we'll get more into that later on. So what's currently in ClinVar? There are over 800,000 individual interpreted variants in ClinVar. So this has grown enormously in the last 6 years since ClinVar launched in 2013. And like ClinGen, this is not limited to the US, but there are submitters all over the world who are contributing data to ClinVar in over 60 countries now. Over 1,000 submitters have contributed data. And we clearly like to emphasize this point that it is a submitter-driven resource. So there are many pieces of information that ClinVar can collect on a variant, but if a submitter does not submit them, they aren't available. So what you see in ClinVar has been submitted, and what you can't find in ClinVar, if you're searching correctly, just hasn't been submitted yet. So the quality of submissions vary, and when assessing the information you find in ClinVar, you must assess the quality of the submitter submission itself. And the way we have a guidepost to help you assess the quality level of review, if you've used ClinVar before, you may be familiar with the stars at the top of the page. And that just indicates what level of review the submitter has attested to. So if a submitter has provided the criteria they used to evaluate variants along with some of the evidence they used to evaluate that variant, then they are given at least 1 star. And the expert panels that we talked about earlier are given 3 stars. So it's not saying that one is more correct than the other, but we know that the more stars, the more rigorous an evaluation that variant has undergone. And the stars can also be used to point out the concordance of interpretations. If multiple groups have submitted interpretations on the same variant, if they are concordant, there'll be 2 stars, and single or discordant, 1 star. All submitters have the option of providing supporting evidence. The uptake is variable. And for your purposes, the most informative submissions are those that clearly outline the evidence that was used to arrive at the interpretation. So we know from all the users that we've talked about, it's those submitters who not only say we think this is pathogenic, but either here are the ACMG AMP codes we used to come to that conclusion, here are the PubMed IDs where we found the evidence, or here's the description of our laboratory's evidence, are really the most fruitful for someone else assessing that variant. And now that we've talked so much about it, Stephen is actually going to walk you through just ClinVar itself. And again, this is from the perspective of someone wanting to use and evaluate data that they find there.
All right. So I'm just going to open up browser here to ClinVar. So I'm just going to walk through just a few searching techniques and then sort of what is on the page when you land on a specific variant. So you can search with genomic coordinates, protein change, cDNA change. In this case, it's going to have a specific variant of interest here. Let's say it's 5401G to A change. I click search. And you can see I'm getting back multiple results of all different variants within ClinVar. And you can see that some of them, the C dot is matching. It's 5401G to A, 5401G to A. But then you're also seeing these ones where that's not the expression. So why would these be returned? And the reason why is thankfully ClinVar is able to map a change across all different transcripts. So I'll open up a record here real quick to show that if you look at all the different expressions of this variant, you can see on some transcripts it's this C.11683 change, but on another transcript it is this 5401G to A change. And this is nice because let's say you're using a different transcript than maybe another lab has. If you come to ClinVar to search for your variant, it should still be able to find the correct variant because ClinVar will map across all the different reference sequences that are applicable for this variant, and we'll be able to return results based on those. So it's one of the benefits of them being able to do all this mapping. But in this case, let's say this is the variant I want to look at, this MYH7 variant. So up at the top is the preferred name within ClinVar, and this If it's within a gene, they pick the most relevant transcript and express the change relative to that. And then up here, you can see this review status that Danielle had mentioned. So it is a 3-star, meaning reviewed by expert panel. There are 8 submissions, which I'll show in a moment. And another important tag here is this FDA recognized database. At the end of last year, ClinGen interpretations were recognized by FDA as being part of this FDA clinical grade database. So the interpretations from the ClinGen expert panels now get this additional FDA grade recognition and tag on the variants. And I'll show at the bottom of the page where the interpretations are that you'll also see the FDA tag there. In this middle section, and actually if people are familiar with ClinVar, you may have noticed in the last few months the display has changed in ClinVar. So this is the new display. So things are a little bit different than they were if you had looked maybe a few months ago. But this sort of middle section on the page is all information that ClinVar puts together. It's showing all the different expressions of this variant, both genomic as well as NM changes. And so what's nice is from a submitter's perspective, I only have to submit one way to express this variant. I could submit this variant with the genomic coordinates. Another submitter might submit this variant with the NM and C dot change. And ClinVar is able to aggregate and put these together and know that these are all the same variant. So don't think that you have to provide all these expressions when the time comes to share any information in ClinVar. You only need one expression for your variant. And in addition, there are sometimes links down here to go look at other databases, like if the variant was in NOMAD or 1,000 genomes, there'd be links here. There's also information about what gene the variant is impacting, if it's gone through a dosage curation to know if there are, if it's known to be haploinsufficient or triplosensitive, and then also lets you know how many variants are within this gene in ClinVar. So the part that most people look at when they're in ClinVar is this bottom part of the page. And so this is showing each individual interpretation submitted to ClinVar. So in this case, there are 8 different interpretations, each with a row here. And so you can kind of read it from left to right as far as the context. So this is likely pathogenic for primary dilated cardiomyopathy from the ClinGen inherited cardiomyopathy variant curation expert panel. And so this is the one that gets that FDA grade designation here. And then as you go down, you can see there are other interpretations as well, a pathogenic here from Blueprint, a likely pathogenic from GeneDx, and so on. And I think, yes, there were 8 interpretations total. And what's helpful is if someone has provided their supporting information that explains why they have classified this variant as pathogenic, those descriptions appear here. And ClinVar has heard from users that this is often the most useful piece of information within ClinVar when they've seen an interpretation, is being able to know why it was classified the way it was. Because from a variant interpretation perspective, if I just see that someone has called a variant pathogenic in ClinVar and provided no evidence, I can't really use that interpretation in my own assessment because they didn't provide any explanation for why they called it pathogenic. So being able to see the explanation is a really helpful field. And additionally, if they have cited PubMed articles, the PubMeds from each submitter are listed, but then also thankfully at the bottom of the page, ClinVar lists every unique PubMed ID that has been associated with this variant from different submissions. So this is a helpful way to be able to look at all of the unique PubMed IDs that do reference this variant, so that if you are doing an assessment of this variant, you can sort of see all the different publications that have been here. And these are driven by the submitters, not ClinVar doing some search of all records that might or all publications that might reference this. The only other thing I'll note is if you are searching ClinVar, there is a I can't remember where it went. There's a page about searching. Oh, I think HBS expressions. Oh, it's not loading here.
You go back up to ClinVar and go to the main page.
Oh, yeah, sorry. On the main page, on the about. Oh, yep, here it is. Help. How to search ClinVar. It gives all different types of examples for searching. So let's say you have genomic coordinates. It'll tell you how to put in genomic coordinates and search that way instead. If you want to search by a gene, what you could do, you could even search by a submitter. So this kind of walks you through different scenarios of how you could search ClinVar if you don't just have a C dot change or something you want to use, but you have a more specific idea in mind for your searching, you could use this. All right, so I think we'll go back to the PowerPoint. I walked through most of these searchings, and we can jump to the actual submission process.
Any questions about just searching ClinVar for data?
And again, you all can dial *6 to unmute yourself if you have any questions.
All right, I guess we'll go to our ClinVar submission.
And we'll circulate these slides after the call. We did lay out a number of the searches step by step that Stephen just went through the different filters you can apply as well. So if that is something you'd like to integrate into your practice, there's more of a step-by-step way to approach it. All right, so now if you are sitting on a bunch of interpreted variant data that you would like to get out there and to join the other submitters in ClinVar, we'll just walk you through the ways that can be done. And again, it's not just limited to clinical testing laboratories who can submit to ClinVar. In ClinVar now, there are researchers, clinicians, locus-specific databases, variant curation expert panels, such as those from ClinGen, and even patient registries have begun submitting data from their consented participants to ClinVar. And the clinicians are a much smaller set of ClinVar submitters, but we have been getting questions about them more and more often. So we do like to point out the use cases for clinicians. We think the use case for clinical laboratories is rather clear at this point. The clinical laboratories are the ones interpreting variants, putting it on test reports. We'd like to have a central place where all those interpretations live, but what additional information can clinicians contribute? Well, clinicians are welcome to submit data regardless of whether or not the testing laboratory that you use also submits, because you do have valuable information to contribute. We know that there are some clinicians who may reinterpret the variant after they get it from the laboratory, so they may want to add their own interpretation. And again, this wouldn't override what was already in ClinVar, but it would be aggregated along with it. That's a collection method called provider interpretation. Or you may want to submit information on a case you've seen with a particular variant. You don't want to add an interpretation to it, but you want to provide, if you have appropriate consent, more detailed phenotype information so that others who identify this variant and look it up in ClinVar can see the phenotypes that were observed in the same person who had it. That collection method is called phenotyping only. And both clinical laboratory and clinician submitters, one of the first questions when someone's preparing to submit is, do I have permission to submit this? Do I need consent from all of the patients I've tested over the years before any of this data can go into ClinVar? So first, ClinVar assumes you have attained appropriate consent to submit the data, so they won't be doing any checks or balances on their end. The onus is on the submitter to ensure that they have obtained the appropriate consent. But because we know this is such a popular question and there isn't a lot of clear guidance, ClinGen has done a lot of thinking about this. I'll just share with you now what we've come up with. So one thing to always keep in mind is that ClinVar is a publicly accessible database. The information is available if you Google it. So because it will be out there for unrestricted distribution, it's always just a good thing to keep in mind about what you're sharing. Certainly any submission, whether it's on one case or multiple cases aggregated together, submissions must remove any HIPAA identifiers. Because the data is de-identified in this way, although we know there's all sorts of complexities around the identifiability of genomic data, explicit consent is technically not necessary for variant-level submissions, and we'll go through what we think of as a variant-level submission. but obtaining consent may be needed in order to share more detailed individual level information about a particular case. So the more information you add about one person, certainly the chance that it could be re-identified increases. So that's when it's always worth taking to your IRB or some other ethics board, reviewing the case with them before proceeding for individual level data or case level data. But for laboratories and maybe clinicians as well who want to submit variant level data, the majority of the data they submit to ClinVar is variant level. And when I say that, I mean they are not just saying we saw this variant in patient Jane Doe who is this many years old and has this diagnosis. They're saying we've seen this variant, which we have interpreted in the context of this disease. We are calling it pathogenic, and we have seen it in 5 cases. Those 5 cases, 3 people were affected, they were of this ethnicity, so on and so forth. So there may be a lot of evidence collected around that variant, but not all of it points to any single individual. So the individuals who the variant was observed in and whose evidence was used to interpret it aren't themselves identifiable. So we laid this out in a paper, Points to Consider for Sharing Variant-Level Information from Clinical Genetic Testing with ClinVar. And if you're a laboratory that hasn't shared data yet with ClinVar but are thinking about it, we would point you towards this just as a guide for what elements can be shared in the public setting without explicit consent. So this was written along with the NCBI ClinVar team, representatives from NHGRI, and also representation from the Global Alliance for Genetics and Health Regulatory and Ethics Working Group. We did have their insight into this as well. And that includes a description of the variant, the clinical significance assertion, so pathogenic to benign, condition and inheritance pattern on which the assertion was based, the name of the clinical testing laboratory, so yourself as the submitter, and evidence on which the assertion was based. And again, this is a summary of all the cases that you've seen. So what data can you submit? The variant level data, as we just went through in aggregate, with an interpretation of either the clinical or functional significance relative to a condition. We've mainly been using examples from the germline context here, but ClinVar does accept somatic interpretations as well as pharmacogenomic interpretations. However, ClinVar does not accept large sets of uncurated variants from GWAS studies. Variants that were observed in a patient but not interpreted for clinical significance. So this isn't a database to upload raw sequencing data to. Variants with classifications based solely on computational predictions, and entire sets of variants identified in a single individual. And next, there are several methods for submission, and so your next step would be deciding how you'd like to submit, and I'll turn this over to Stephen.
So ClinVar has a handful of options where you could submit. The most common are using either this Excel spreadsheet method I'll talk to, or using something called a submission wizard that ClinVar has made for being able to do one-off submissions. So if you're interested in what the spreadsheet looks like that you would use as a template for sharing on ClinVar, if you're on the home page and go up to submit and then spreadsheets is one way of being able to, it'll then take you to the place where those files are saved. If you download it and open this, it is overwhelming when you first open it because there are a lot of fields. I can't remember exactly how many, but there's a lot. And it's because they want to allow for every situation and all different types of data. So don't be overwhelmed by when you first open it and see all the different fields that ClinVar is asking about, because in reality, very few are actually required fields. So the ones that are actually required are information about yourself, so, or not yourself, but the lab that you are going to be interpreting for, a description of the variant, and this can be, again, a genomic change. You can do it with regards to a RUSP transcript. You could use a VCF format. You can do cytogenomic changes with, a min and max of a, del or dupe. A condition for which the interpretation is with regards to the actual interpretation of the clinical significance or even maybe functional significance of that variant. how the data was collected, and this was that collection method that Danielle mentioned where there are those options for provider interpretation, phenotyping only. So the vast majority of information in ClinVar comes from this collection method of clinical testing because it comes from clinical laboratories, but there are about maybe 8 to 10 different options within this collection method field. They also then just ask the context of if this interpretation is in the context of germline versus somatic, and then if this variant was observed in someone who was affected with the condition or unaffected, but they also do allow a not provided for this field. So even though it's required, you can also say not provided for the affected status. So then the other option is this idea of using the submission wizard. So this, you have to, in order to share with ClinVar, you actually have to create an account with their submission portal, where you kind of go through and just, identify who the lab would be, the name of it, contact information, things like that. Once that's gone through, they then create, so this is a lab that I have submitted before, Laboratory for Molecular Medicine. When it comes time to submit, you can see I have two options. I can either upload my submission file, which would be that Excel spreadsheet that I could have created, or I can do this thing called a single submission wizard, and this is for individual variants, so you would submit one variant at a time. So if you have maybe only like 5 variants to submit, going through the wizard is maybe more time effective for going through the process, but if you have, 10 or more, I would say probably using the Excel spreadsheet is a better way to go. And using the wizard, it asks some of the same basic information that you would see in the Excel form. It's asking for you to identify the variant. Again, gives you multiple options of, in this case, I've selected I'm going to do HGVS with regards to a build 38. I'm giving them the transcript, the cDNA change, and what the gene is. I can identify the condition, and they use IDs from either HPO, MedGen, OMIM, even OMIM phenotypic series, Orphanet. They allow multiple different disease ontologies that you could use to indicate what the disease of interest is, or you could even just use free text to describe what the condition would be. And then your interpretation. So, benign, uncertain, pathogenic, a mode of inheritance, if applicable, and then any explanation about why you are classifying the variant the way it is. And again, this is an optional field, but highly encouraged because having some rationale for your interpretation helps people understand why you came to that conclusion. And then this is where that appears if you do write that summary. This is with the old display, but it's still, anything you write in that field is then public for anyone else to be able to look at. And then, yes, then it just sort of shows everything, and you can then click Submit at this point. It will also say the ClinVar processing time, I think, is much quicker if you go this route versus the Excel, because it sort of has already done quality checks as you're going through the process. So it may be, not exactly sure of their turnaround time, but it would maybe be a week or so before the data goes live in ClinVar, whereas through the Excel spreadsheet, the turnaround time can vary. It's often more than a month or two before the data would go live, just because ClinVar has a large queue of data that they are constantly being submitted to them that they have to go through and process before going live. Oh, yep, and then yes, once you've submitted, so the ClinVar staff will review your submission. They're actually working on a process right now where the different variant expressions get validated at the time of you entering it. So it sort of identifies any issues at that point before it gets to a person on the ClinVar side to actually look at it. So they make sure that all the formatting is correct. And as they're going through the process, they will often contact you with issues or questions of, oh, this, the position you said is the, what you gave as the alternate nucleotide is actually the reference, or, the gene seems to be misspelled for this field, things like that. And then once your data goes live, they give you a what's called an SCV number. And so this is ClinVar's accession number for each individual interpretation that is in ClinVar. So this is different than a variation ID, which ClinVar gives for this variant in ClinVar, and here's everything that's known about it. Each individual submission gets this SCV. And so from a submitter perspective, these SCVs are helpful for me because if I have now reclassified a variant and I want to tell ClinVar, oh, I know I previously called this variant uncertain, but now I want to change it to pathogenic, I need to give ClinVar my SCV number and tell them, now change this classification to something else. So you want to keep these SCVs, because otherwise if you try to go update something in the future and don't mark it as an update, ClinVar treats it as another novel submission. And then, you would have two different submissions in ClinVar where you'd want to have it update and overwrite your old classification as opposed to your newer, as opposed to showing both. I'll turn back over to Danielle to go through some of the benefits. We're just working on a document that has some of the benefits of using and sharing in ClinVar.
Yes, so now that we showed you the process, you can probably put that in the context. If you do have more than 10 variants to share, you can see how sharing could be an onerous process. But ClinGen, and I just think a bigger group now in the clinical genetics community, is really getting behind this, that it is worth the work, and something that our patients are relying on us to do is share information to improve our knowledge. So we have put together, I'm actually going to just go right to our benefits of data sharing. Well, I'm going to take you to our website. That's what I'm going to do. Technologically challenged. So now I will take you to our website.
And while you're doing that, Danielle and Stephen, can you talk a little bit about data sharing concerns or, sort of any guidelines that laboratories should think about for data sharing?
Sure. So I would, I think the first place to start would be this guidance that was published in the Cold Spring Harbor molecular case studies. And we really did that with clinical laboratories who are submitting variant level information in mind. So, how to balance the benefit of sharing with the risk of potentially identifying one of the patients that you tested. So this is just one table from that document, but it goes through the whole thought process of what we think can be shared when it's not realistic to obtain consent from the vast number of patients a laboratory has tested who weren't consented for data sharing. So that's one of the first places I would send you. Were you thinking about the privacy and consent issues, or is there is related to another aspect of data sharing?
Well, as you guys know, newborn screening is a public health program and it's not consented. So as genomic sequencing is being increasingly used, I think we're sort of haven't figured out if that's going to happen within the public health arena or if a clinician's going to order it, and then there might be some consenting. So I think we're just kind of thinking through how do we navigate something that's generated in a public health program where it's not consented versus something that's done in the clinical arena where it might be consented to do the testing, but as you said, not necessarily for the data sharing. So it's just some things we're thinking through. And I think this document, as you point out, will be a helpful starting point.
And I would say, I think when we started in 2013, when ClinVar was launched, and we started asking clinical laboratories who hadn't shared data publicly before then, because there really wasn't a forum to do it, a lot of them were faced with that, that question. And the really promoting this variant level or summary level approach, I think, was the happy medium that everyone agreed upon, because by aggregating all the observations that you've seen, it really does help decrease the chance that any one of those individuals would be identified based on the information you shared. And we do outline in this paper for N of 1 cases, can those be shared even though it's aggregate information? If you're aggregating the information on one person, we can pretty much deduce who it is. So we do have a section on that and what could potentially be shared, in that case keeping the patient's privacy in mind.
Great, thank you.
And we would, so I will go back to the benefits of data sharing in a moment, but I'll bring up this resource slide just to go through all the different people that you could contact if this presentation has brought up any questions. And ClinGen really does want to serve as a resource for anyone who is looking to share data, has questions about data, or has barriers to sharing data, because the clinical data sharing realm has really been unnavigated territory, and we're trying to work with everyone in the community, those who want to access the data and those who want to share it, to kind of figure out some of these obstacles, because if you're faced with a question, it's probably one that someone else has asked or someone else is thinking. So I would encourage you for any questions, not just about specific data and how to get it into ClinVar, but the bigger policy questions, to email clingen@clinicalgenome.org. That goes to myself and another one of the coordinators who thinks a lot about this, and we can make sure your question gets to the right spot. And we also hold several monthly calls with the ClinVar team where we work with them through some of these big questions. So you would never be bothering us with some of these hypothetical questions or things you want to work through, because we're hoping to help you with those.
Great,
and
thank you.
Yeah, thank you. And another thing almost related to that, but when we were asking some of the, especially the bigger laboratories where it wasn't up to the lab director whether to share data, it really goes up to the C-level leadership on whether they would allow their proprietary information into the public domain. So a request that we got from the lab directors and people in the lab who wanted to petition the higher-ups and say, no, this is something our laboratory should be buying into, this is something we should be endorsing. They asked if there was some documentation that they could show to show this is of a benefit to the field. So we have this document that we update every few years. This is available on our website, and there'll be a link in the slides that I send out, but I can share this as a separate PDF as well. And we just go through some of the reasons that ClinGen and everyone we've worked with in the community thinks that there are real benefits to sharing variant classifications and evidence with ClinVar, including improved variant classification. And there's several references to the work that Stevens led on once discrepancies and interpretations are identified through the aggregation of data in ClinVar, laboratories can then work together to resolve them, leading to consensus in the field. It includes keeping providers up to date, because when we educate providers about finding the most up-to-date information in ClinVar, they don't have to keep requesting updated reports from a laboratory, but if they know their laboratory is routinely submitting to ClinVar, they could use that as a first stop. Adding value through standardization and quality control. So by using, sharing data in this central place, we really had to come together on what clinical significance terms we were all using, what conditions we're all ascribing to these, to the conditions out there, what ontologies are we using is what I'm trying to say. And so forth. So by standardizing the information to share it, we are really doing a favor to the field. And then publicity through sharing data. So ClinGen has several ways of recognizing laboratories that, that meet what we've set forth as minimum requirements for data sharing for quality assurance. The submitters are also all listed on the ClinVar website. And the genetic testing registry, where people go to order testing, also lists if you are a ClinVar submitter or not. And something that we know more and more clinics are doing is preferentially choosing testing from laboratories that share their clinical data. And I know this is slightly different from the work that you all do in the public health sector through a newborn screening program. But if you, wear another hat in a clinical laboratory, this may be more applicable there. And also, at the beginning of the presentation, when we talked about the professional societies that had endorsed data sharing, it really is keeping in line, even if it isn't a mandate, but keeping in line with the evolving thought in the field. And there are references to go along with that if anyone wants the rationale for where those benefits came from. And with that, there's just some websites here. ClinVar has a lot of documentation on their website to not only help you navigate ClinVar and the acceptable searches to use, but also how to submit your data. And on the ClinGen website, you can learn more about those expert panels I mentioned, the work we've done in data sharing and curation. Lots more we could talk about, but we're always happy to field questions afterward. And one thing I know that our partners at ClinVar have said, if you start filling out a submission template and you're getting frustrated, but you're just going to dump all your data in there, they are certainly open to you trying out 1 or 2 variants and sending that template along to them, not as a formal submission, but just as a test to say, hey, can you give me some feedback on how I entered this information, because I want to make sure I'm on the right track before I put all my information in here. So that is something they certainly welcome. So we just want to make sure that everyone's aware of that. And with that, that's what we put together. I'm happy to take any more questions.
Thank you. That was really, really helpful. I think, as we sort of framed at the beginning, this is just starting to become, something that we're hearing. We have these calls every month with the state newborn screening programs and clinicians, and we're hearing about the identification of variants as unknown significance. And, it's becoming increasingly clear that the state newborn screening programs are going to be, one of the entities that generate new knowledge about variants in these rare diseases. So with that, is there anybody that's on the line that wants to talk a little bit about how this might impact their program, or if you think we're sort of getting ahead of ourselves and, we're not quite sure if sequencing is going to be part of the newborn screening program, or if it's always going to be under the purview of, the clinician. So we would love to hear a little bit about that. And if you're not able to unmute or talk about that today, we can definitely make it a topic for our call next month.
Hi, this is Stan Shortino from State of California Newborn Screening Program. We've been collecting data on various disorders and genetic data, especially cystic fibrosis, since 2007, and we have historically just published mutations and variants based on whether or not we've observed cases of cystic fibrosis or not, and we've done that every 3 or 4 years, and I'm actually working on a large database of all our variants and about ready to make that, or at least part of that, public, and which we would happy to share with ClinVar after we get the okay from Sacramento. But one thing is, what do you do with legacy names for ClinVar? Because this is what we have, mostly legacy names for a lot of these variants, and then we have to hunt around and figure out what the cDNA or pDNA names are.
Yeah, so ClinVar does have a field. So let's see, if I search here Delta 508, I think the variant will come up. Let's see if this actually is true.
So I just downloaded your data yesterday. It was just kind of interesting to match with our own. And we did match pretty well with cDNA, but not the other names.
It actually didn't bring it up. I thought it would.
If you look at, that's the gene.
Let's do. So one thing that ClinVar does have, see if I can find one that does this, is they will have, they sometimes will have this field for other names, okay. And that's where they will put in legacy so that if someone is searching, it would come up, but you can't only use that name when you submit to ClinVar. You would need a, some sort of HGVS expression to let ClinVar be confident in the variant you're talking about, but there is a column in the submission form to provide other names for that variant, and then ClinVar does bring them in here so that people can search that way. So you would first have to map your legacy names to more standard names.
Okay, great. In any case, we've had no problems getting agreement to, if you have one kid with a mutation, we have published those. But we don't give a lot of information about the child at all. We retain confidentiality very well by just saying, oh, the kid had CF and this mutation,
Yes, and I thought that's, I started working at clinical lab as well, and I thought that is about the level that we will say as well of, this variant was found in 3 people with CF, all of whom had, either the variant homozygous or another variant on the other allele or, things like that. But yeah, we will, say what disease it is, but not necessarily get into, specifics about certain, levels or anything like that in the patient.
Okay, great.
And if you are publishing individual variants, ClinVar, if you want to do the ClinVar submission in parallel, ClinVar can assign you an accession number but hold it until publication, and that way you could reference your ClinVar accession number in your publication, which would bring people right to the page, and it could be aggregated with any other interpretations that have been submitted.
Okay, excellent.
Do we have any additional questions?
So Andy from the Utah program, do you think this will be helpful if you're still on the line? And unable to unmute yourself. I know it's not always easy. So Danielle and Stephen, can you tell us, what's the percentage that are submitting, between clinicians and laboratories? Is there any feel for that, or you might have already covered it and I might have just missed that?
So the majority of data, or the percentage in data that breaks down between clinical labs and clinicians?
Yeah.
Right now, I'm going to do a rough percentage and see if Stephen agrees with me. I think maybe over 80% of interpreted variants in ClinVar come from the clinical laboratories, followed by research laboratories or locus-specific databases. I think the submissions from clinicians right now are fairly small, although we do find them to be very valuable. But right now, it's really the clinical laboratories who have taken the lead.
Yep, and I think with ClinVar rolling out this submission wizard and now having these different collection fields more for clinicians, we're hoping to maybe then see an increase in interpretations that are coming from clinicians. But yeah, the vast majority are from clinical labs, just because volume-wise they're seeing so many more variants every day that they just account for so much more in ClinVar.
Thank you. And I know Dr. Gelb wants to say something, but Dr. Gelb, Danielle Ekema, you can correct me, it's *6 to unmute yourself.
That is correct, *6.
Can you hear me? This is Mike Gelb.
Yep,
yeah,
we can
hear you.
Sorry?
We can hear you.
Yeah, I have kind of a very difficult question, and I think I got a sense of it, but I'm worried about the annotation. I just looked on ClinVar. I looked at some genes. It says benign. So we have difficult problems in this field. It depends on the context, right? So you might have a mutation, patient doesn't have the disease, but depends on the context of the mutation, right? The mutation might reduce the function of the protein a lot, but not completely. And then so it depends on what other mutations you have in the same allele. And the second problem is, some mutations cause a disease when combined with a severe mutation on the other chromosome, on the other allele, some don't, right? So we have a big mess in the annotation field. And I guess your answer would probably be that you're going to have this stuff annotated by a panel of experts. But I worry. It says benign, you know, and sometimes it's not benign. The cystic fibrosis people are well aware of this. You know, they think it'll never be annotated properly because you have lots of cases of cystic fibrosis where you have a combination of partially penetrant mutations and they all add up to a disease. And so can you just say a little bit about your annotation process, and maybe you need to have a banner on your website that says this annotation is just, you know, it's what it is. It's not necessarily accurate. If it says benign, it might not be benign. I mean, I don't know what to do about this problem.
Yeah, I will say for that part, having the disease context does help, because there are some genes that have, you know, a dominant disorder associated with them and recessive. And so being able to say it is, you know, the pathogenic for this disease, but then maybe benign for another, or things like that, is important of getting to that detail and not just saying.
That's not what I asked about. I asked about combinations of partially penetrant mutations that cause a disease. So if you have, you know, 4 out of 4 of these mutations, you have the disease. If you have 3 out of 4, you don't. So if somebody finds the 3 out of 4 guy puts it in benign, and the 4 out of 4 guy with the disease says partially penetrant. So how do we deal with this problem? It's a very nasty problem, and it's one of the reasons why some people think we'll never figure this out with genomics. So how do you deal with that?
So this is separate from the ClinVar topic, but recognizing the complexity here, ClinGen does have a working group for low penetrance at risk alleles where they are trying to standardize the nomenclature there, with the hope that once there is agreement in the field, it would be recommended to use that terminology in ClinVar, just as we have asked everyone to use the now standard pathogenic to benign for Mendelian fully penetrant disorders. So I think that the work of that group, the risk allele and low penetrant. I mean,
most variations are partially penetrant, of course. That's the problem, and so a lot of, I'm just, you know, the problem we have is, maybe we can't discuss this now, but the problem is we find lots of variations of unknown significance or whatever, and we report them to ClinVar, and we don't really know what their disease status is. We don't have enough data to say that. The easy ones are easy, we all agree, but the partially penetrant ones are the ones that are the majority of the cases and cause the problems. And I guess, just give me an example. If somebody writes in and says benign, how is that vetted at your end? Why should we think it's benign?
Yeah, so ClinVar doesn't review any of the information. It is all up to the submitter. So it's helpful when the submitter provides some rationale, so that there is, if someone comes across that variant and they see that someone's called it benign, there is an explanation for why they've classified it that way. Because yes, otherwise if you just see the term, it's not necessarily that helpful to only see the classification and no idea about why it was classified the way it was.
So do you think it's important to put a
ClinVar? So ClinVar isn't vetted, but ClinGen provides the vetting and the curation and the other information. And I realize it's 3 o'clock Eastern, but we did get one extra question from Joan Earhart, who was wondering if it's possible to capture information on synergistic effective variants in combination cis and trans. And if that's too complicated of a question, we can always follow up after this call, Danielle and Stephen, and you can kind of see there's a lot of interest from the newborn screening community. So we might have to get on your calendars to have you come back for a question and answer session maybe in a month or 2.
Yeah, so it's like ClinVar does allow haplotype submissions. So if if the effect is only, multiple variants together, they will allow that. So like, here's a haplotype variant here. And if there are then interpretations of those variants individually, they also tell you those variants have been interpreted on their own too, and you can click here to go see those interpretations. But when there is something like that haplotype or the more complex, ClinVar is able to handle both haplotypes as well as in trans occurrences when that is necessary.
Great. Well, thanks everybody. Thank you, Danielle and Stephen, for a great presentation. And as I said, we'll share the slides, and we have a recording of the call today for folks to listen back to, and we will follow up. If you have any questions about the call today after you think about it, just feel free to send them in, and we will forward those to the ClinGen team. And again, thank you so much for sharing your expertise, and have a great rest of your day, everybody. Thank you.
Thank you.
Thank you.